Pursuant to the orders of reference of April 11th and April 20th, 2020, the committee is meeting for the purpose of receiving evidence concerning matters related to the government's response to the COVID-19 pandemic. In order to facilitate the work of our interpreters and ensure an orderly meeting, I would like to outline a few rules to follow. Firstly, interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. If you will be speaking in both official languages, please ensure that the interpretation is listed as the language you will speak before you start. For example, if you're going to speak English, please switch to the English feed, then speak. And if you're going to speak French, then switch to French and so forth. This will allow better sound quality for interpretation. Before speaking, please wait until I recognize you by name. And once questioning starts, the witnesses can speak as appropriate. When you are ready to speak, click on the microphone icon to activate your mic. Should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. A reminder that all comments by members and witnesses should be addressed through the chair. When speaking, please speak slowly and clearly. When you are not speaking, your mic should be on mute. If you have earbuds with a microphone, please hold the microphone near your mouth when you're speaking. Should any technical challenges arise, please advise the chair or clerk immediately, and the technical team will work to resolve them. Before we get started, can everyone click on their screen in the top right-hand corner and ensure they are on gallery view? With this view, you should be able to see all of the participants in a grid-light fashion, and will ensure that all video participants can see one another. I would now like to welcome our witnesses. From the Canadian Association of Retired Persons, we have Ms. Marissa Lennox, Chief Policy Officer. From the Council of Senior Citizens Organization of British Columbia, we have Ms. Gudrun Langloff, immediate past president. For the Conseil pour la Protection des Malades, we have Paul Brunette, president. From the Office of the Seniors Advocate of British Columbia, Isabel McKenzie, Seniors Advocate. From the Canadian Association for Long-Term Care, Jody Hall, Chair. And as an individual, we have Pat Armstrong, Distinguished Research Professor of Sociology, York University. So we will begin with the Canadian Association of Retired Persons and the Council of Senior Citizens Organizations of BC. So I understand that you will share the slot with 5 minutes each. So please go ahead, Ms. Lennox, and I'll signal you at the halfway mark. Please go ahead. Thank you. Ms. Lennox, you're muted.
I hope that didn't cut into my 5 minutes. Thank you all for having me. And Ms. Hall, nice to see you again. We spoke together at the in front of the HESA committee. So I'll get started. CARP is a national not-for-profit, nonpartisan organization with 320,000 members in every province and territory across Canada. It's important to distinguish that while a lot of our members are retired and enjoy above average education and income, an overwhelming majority consistently support that CARP represents the interests of all older Canadians across Canada. We believe that all older adults deserve to live in dignity and with respect, regardless of income level, family support, and health challenges. It is within the following areas of healthcare that COVID-19 has undermined these fundamental principles of aging well and revealed that a lack of planning and preparation that would secure the health and well-being of seniors during a pandemic. The first and most obvious is in long-term care. If COVID has revealed anything, it's revealed that we warehouse frail and often very ill seniors in unsafe situations which are underfunded, understaffed, and often with little or no certified training. And we expect individuals and or their families to pay a significant part of the privilege to be in those facilities. Third, we place both residents and staff, we placed them at immense risk by not prioritizing the availability of PPE in long-term care soon enough. Too often, health system planning stops at the budget line of what government funds, and we think it's time we reconsider this during a pandemic. It is unconscionable that of 5,000 deaths in Canada so far from COVID-19, 82% were from a population whom we're duty-bound to protect, and we failed. And this is not the responsibility of the federal government alone, but it is the duty of the federal government to make sure it doesn't happen again. If we've learned anything, it's that we didn't have a real plan in place for seniors in long-term care in this kind of pandemic, in spite of having advanced warning from other countries, seeing previous crises of similar scale like SARS and MERS, and the experience with seasonal influenza that spreads in these settings and claims senior lives annually. These are our most vulnerable members of society. We can and we must do better. The second is really around home care supports. CARP has long been examining the positive outcomes of other countries around the world who've met the challenges with long-term care with innovative solutions in leveraging home care options. Denmark, Norway, and Finland are a couple of examples. In Canada, it's reported that at least 20% of residents in long-term care could have their needs met at home. That said, for those who are leveraging community-based home care supports with personal support aides, workers, and other in-home supports, there were several issues that arose as a result of COVID-19. The first, a lack of PPE, along with the cross-utilization of personnel between retirement care homes and individuals requiring in-home supports, contributed to a greater rate of community transmission in both settings. And the second is that there was a clear lack of direction and guidance for caregivers and family supports, reinforcing that in-home caregivers were not considered as part of the pandemic response. And the third issue I'd like to raise is around surgical backlogs. Many diagnostic, treatment, and surgical activities have fallen victim to the focus on COVID-19, including a reluctance of Canadians to seek treatment for new non-COVID symptoms. This is not just a possibility, it is very much a reality today, and CARP fears what this might mean for the health of our older populations who suffer both chronic conditions as well as life-threatening disease conditions such as cancer and cardiac care. Attention to this backlog and conditions requiring such care need to be prioritized. If I have time, I'd like to draw your attention to two more things. Do I?
You have a minute?
Okay. I'll be quick. So the first then is around protections for vaccine preventable illnesses in older adults. As initial information suggested that COVID-19 was a precursor to an advanced pneumonia type response, this has created serious concern within the older adult community. VAC has previously reported that they anticipate that less than 10% of older adults are fully up to date on their vaccines, and a follow-up survey of individuals showed that that number may actually be closer to 3. Older adults do not have the same access to mass vaccination programs, such as those administered in schools to children. Seniors now are now more aware than ever, are hyper concerned about other potential weakenings of their immune system and want a fighting chance if they contract COVID-19. As CARP helps to communicate the importance of routine vaccination as an important part of the health care of an aging population, this also represents a great opportunity for the government to achieve maximum uptake on vaccines in older adults. This has been echoed by our 26 chapters across Canada in both rural and urban areas. CARP is looking for vaccines to be among the first inclusions in provincial or any potential national pharmacare formularies, with the public funding and inclusion of the best-in-class vaccines to combat seasonal influenza, pneumonia, and shingles in older adults.
That's 5 minutes.
Especially as we prepare for a second wave of COVID-19, this will provide seniors with baseline protections. Thank you.
Thank you. We go now to Council of Senior Citizens. 5 minutes, please.
I had to unmute. Hard to find those buttons. In any event, we are part of the Council of Senior Citizens Organizations of BC. We are the largest independent volunteer-run and operated federation of senior organizations in British Columbia. We have approximately 100,000 members, and we come from all socioeconomic backgrounds. We are very proud to be nonprofit and accept no commercial sponsorships, example from donations from pharmaceutical companies or for-profit service providers. So as citizens, and senior citizens, we are proud to extremely grateful that Canadians have responded to the call for action to reduce the transmission of the virus to others, and especially for vulnerable people like us, the seniors. And we thank you all for your efforts in dealing with this unprecedented health crisis. It's caught many of us by surprise. And we welcome the opportunity to let you know our thoughts and recommendations about long-term care in particular and seniors' health in general. And by the way, we appreciated your report on National Pharmacare and are looking forward to some fruition of that. Almost half of the COVID-19 related deaths in Canada were seniors living in institutions that masquerade as care homes. Appalling conditions that came dramatically to the public's attention existed for several shameful decades, long before this pandemic. So much of public policy seems to be based on baked in anti-age prejudice, much like racism or sexism. Combating and eradicating discrimination based on age will take concentrated systemic attention over time. No seniors we know are looking forward to going into care. That's because there's a real reluctance of going into a warehouse to wait for the inevitable, and everyone has heard about a bad story or many more. So in an unprecedented effort of consulting with seniors in care, our British Columbia Seniors Advocate interviewed as many residents as possible. A large number of the interviewees were somewhat reluctant to voice specific complaints beyond the ones about regimented time and lack of showers and that sort of thing. But as well, and very telling to us, was a huge proportion of them confessed that they really did not want to be in there. The reports are available online, by the way, so I won't go into parsing the data. But mistreatment and neglect of seniors represents a violation of basic human rights to security of the person. Allowing that discrimination to exist and flourish is as a result of chronic underfunding of health care and of seniors and other vulnerable people in Canada, accelerating privatization and commodification of seniors' care, no non-existent or ineffective government oversight of international investments in seniors' care, no consistent enforced national standards for care, lack of nationally coherent shared vocabulary in describing services provided offered to seniors. We call for the complete reform of long-term care provisions in Canada and for independent seniors organizations like ours to be consulted in the process. And our recommendations are as follows: that the federal government immediately begin transformational reform of long-term care laws, regulations, practices, and funding levels. Number two, that the federal government initiate a national inquiry into the ongoing privatizations of seniors' care, healthcare. Seniors' healthcare in long-term, number three, seniors' healthcare in long-term care as well as allied care facilities become part of the Canada Health Act. And number four, that government ban international investment in private long-term care homes and phase out private ownership of long-term care homes. Number five, federal and provincial governments ban the contracting out of essential services that protect the health and safety of seniors. And number six, national principles and standards grounded in national and international human rights legislation to be developed specifically to protect the human rights of seniors in long-term care in Canada. Number seven, develop and enforce accountability and enforcement measures based on national reporting systems for regular monitoring of the provisions of seniors' care, and appoint a Canadian seniors advocate to monitor the implementation of these changes and to report directly to government. It is clear that no one with the power to make any changes listened to seniors themselves until now. If they did, there was no effort, there was no evidence that things had changed. The fact that almost half of all the deaths from COVID-19 in Canada are of institutionalized seniors is a wake-up call for Canadians.
Could you wrap up, please?
Okay. The conditions are not new news. Certainly, we've had, I've provided my speaker's notes to the committee, and I urge you to look at those for the final comments. Thank you very much.
Thank you, Ms. Langoff. We go now to the Conseil pour la Protection des Malades. Mr.
Brunet. Hello. Hello, Brunet, Conseil pour la Protection des Malades. We've been in existence for 46 years. This is an independent organization, has submitted hundreds of briefs to the Quebec National Assembly and also to parliamentary committees. The last one was in 2015 during the medical isotope crisis. We analyzed the documents. Testing 1, 2. This is the interpreter on the English channel. Testing 1, 2. Testing 1, 2.
Mr. Davies, can you hear the interpreter on the English channel?
Testing 1, 2. This is the interpreter on the English channel. Testing 1, 2. Testing 1, 2. Once again, this is the interpreter on the English channel. Testing 1, 2. Testing 1, 2, 3. Testing 1, 2. Testing 1, 2, 3. This is the interpreter.
Perhaps you could toggle it.
This is the interpreter on the English channel. Testing 1, 2. Testing 1, 2, 3. This is the interpreter on the English channel. Testing 1, 2, 3. Oh, wonderful. As of the analysis of documents and information obtained and the health emergency in Quebec declared on March 13, 2020 by the government of Quebec, 2 months after the first WHO Sichuan report, we've had no screening or tests in the long-term care homes, in retirement homes, and seniors' homes. However, at this time, 4 notices had already been sent out by the WHO. A confidential note had been given to the Minister of Health of Quebec on concerns with regards to the elderly, and dozens of media reports had been sent out throughout the world, many in France and in the US. They said that there was an alert with regards to seniors' homes and the elderly. Still, according to documents and information obtained, we observe that before March 13, 2020, for the executive head of the cabinet, they were preparing, but for the director of public health, Horacio Arruda, was on vacation for a few days in Morocco at the end of February, and even Premier Legault was on vacation up until March the 8th. COVID-19 does not seem to be a national emergency in Quebec. That means to identify, to screen, to test, to identify seniors. We see that there was an absence of screening, isolation, and treatment measures recommended by the WHO since early February, most particularly with regards to seniors in the long-term care homes, the CHSLDs. So 3 months later, after 4 notices by the WHO, a private note to the Minister of Health on this subject, hundreds of media reports throughout the world, that the Quebec government finally decided to act in the long-term care homes and to do something. In Quebec, 81% of the COVID deaths are linked to people who died in the long-term care homes. A press release in April, my priority is to protect the seniors. François Legault said this, the Premier. On April the 10th, Mr. Legault's entourage learns, as if they were back from a long trip, that COVID-19 has been spreading like a wildfire in seniors' homes and long-term care homes. This is 3 months after the first warning sent by the WHO. The first one was on March 1st.
Is associated with age and comorbid disease. 1er mars, 1st of March.
The Government of Canada and those responsible for the management of health safety in the long-term care homes in Quebec, more particularly, scandalously did not act. This is a scandal. They did not implement testing and treatment options for the elderly and for the staff of the long-term care homes, as was being recommended by the WHO since February the 5th and March the 1st. They affected fundamental rights of thousands of Quebecers and Canadians, people who had the right, the basic right to receive vital care, to not be neglected with bed sores. They have the right to be hydrated and to be treated. Hospitals in Quebec said that some patients were hospitalized not because of COVID, but because they were dehydrated and they were malnourished. The right to security and to not be housed with infected people, the right to integrity of one's person, to not be lifted or changed by staff or volunteers who are often well-intentioned but incompetent. The right to dignity, the right to be treated like a human being, not to be left with a soiled diaper for days, to not be able to be accompanied to or have assistance use the toilet, not to be neglected or abandoned, not to die alone, abandoned, and without dignity. The authorities of the long-term care homes were not prepared for COVID-19, despite the recommendations of the Public Health Agency of Canada since 2013 and the recommendations of the Public Health Agency dating back to 2013 as well. How the Canadian and Quebec governments were they able to leave the elderly in this situation that they were left in without acting more early on the advice of the WHO and the information coming from many countries throughout the world? Is that all? Thank you.
Thank you. We go now to the Office of the Seniors Advocate of British Columbia. Ms. McKenzie, please go ahead, 10 minutes.
Thank you. Good afternoon, and thank you for inviting me to give my thoughts and observations on our initial response to COVID-19 pandemic as it relates to seniors.
Excusez-moi, Monsieur le Président.
And I'm hearing an echo in the background. I don't...
Il y a un problème. Oui, oui. Il y a un problème encore, là, le même problème que j'ai soulevé avant le début de la...
There's a problem, the same one that I raised before the meeting. It's the same problem. The one I mentioned before. So for the whole testimony, the last testimony that we heard, I decided to cope with what I was hearing, but I will not be able to cope with this for 3 hours. The issue needs to be solved. The problem is not with one interpreter, it's with all interpreters. There is one microphone that I hear being plugged and unplugged at the same time as I'm hearing the interpreters work. So this issue needs to be fixed. And I say this at every meeting. I do not want to sound grumpy. It's nice weather here, but it's just unbearable.
Did I perhaps not have my interpretation button correct?
I'm not sure that it's a problem with you, as I think it may be something wrong in the interpretation booth. I would ask the clerk if that's something that we can address right away and whether we should suspend. Let's suspend for a couple of minutes and see if we can sort this out. So suspending right now for a couple of minutes.
So, Mr. Chair, now that we're suspended, There's an intermittent problem on both interpretation channels. It happens in every room. And when it happens, they have to manually reset the audio cards. They're waiting on new audio cards, but just please draw it to my attention when it happens. And when there's a natural pause in the conversation, we will fix it.
Is that something we can do right now?
It should be fixed right now, and I am flipping back and forth between all the interpretation channels at all times and monitoring the problems. So I do tell them when I hear it as well.
Okay, thank you. Mr. Thériault, are you hearing better translation at this point?
Si vous pouvez,
If you could perhaps speak for a little while so that I can hear the interpretation. And I can tell you if there is a problem. Sometimes it's an intermittent problem. Sometimes the problem happens when we switch interpreters. And from one interpreter to the next, the problem stays or remains.
Sounds, Mr. Thériault, like there's a problem with the audio card in the interpretation booth. It needs to be manual reset by times. They are anticipating replacements soon, but they haven't arrived yet. They have done the reset at this point. Are you able to hear the interpretation better now?
Oui, Monsieur le Président.
Yes, Mr. Chair, I am hearing better sound. Thank you.
Keep our fingers crossed, and hardware being what it is, we will keep them very tightly crossed, and we will resume. So resuming the meeting as of now, please go ahead, Ms. McKenzie.
Thank you, Mr. Chair. So thank you for inviting me to give my thoughts and observations on our initial response to COVID-19 as it relates to seniors. And I say initial response because we're not through it yet. And inevitably, we're going to discover some future issues that are not obvious right now, as we're only 2.5 months into what is going to be a year-long or 18-month journey. So I think most of us have seen that as we have responded to this pandemic, fault lines have appeared as it relates to a lot of things in our society and in our economy, but particularly as it relates to seniors. And I think that we need to recognize that the impact of COVID-19 is different for seniors depending on their income, on their social and health status. So what one senior experiences is not necessarily what every senior is going to experience. So I've tried to break it into categories to sort of look at where these differences are. So if we look at the category of low-income seniors, where I think there has been an impact that's different from other aspects of society, and income for seniors, as most of you probably know, they have the lowest personal income of any age cohort over 25. So their incomes are low to begin with. And so they're very sensitive to small cost increases. It's true that seniors have not yet felt an impact from a decrease in income. Pensions obviously have remained the same. Impacts from investment income haven't really yet been felt. That's still to come, and the degree to which that will be felt is still to come. But certainly for low-income seniors, sensitive to price increases, I'm sure there's many MPs on this committee who have constituents, and I'm sure you've heard about the experience of increases in food costs, in part because of actual increases in food, and in part because seniors who normally go from supermarket to supermarket or store to store looking for specials have not been able to do that. And so a $50 or $60 a month increase in your food bill on a low-income senior's budget does have quite an impact. Low-income seniors are also less likely to be virtually savvy in the virtual connections that we have, like these Zoom calls, in part because they're less likely to have devices and they're far less likely to have internet. And one of the things that I think the federal government can look at in the future is how we're going to deal with the ability to provide low-cost internet. We have focused a lot on the provision of internet to all parts of Canada and to rural parts of Canada, and that is very important, but we cannot ignore the fact that internet is also very expensive, particularly for low-income people and particularly for low-income seniors who can't necessarily bundle everything together on a smartphone. So I think for low-income seniors, the impact has been, it wasn't immediate, it wasn't on day one, but it has compounded over time, and I think will continue to compound as they are susceptible to these small price shocks that I think we're going to see over the next year. And then there's the issue of seniors living alone. So as we practice our safe distances, our 6 feet apart, and as we isolate at home, and certainly as seniors are made aware of the need more so for them than others to stay away from people, we need to recognize that seniors are more likely to live alone. So for people over 65, and especially for those over 85 relative to others in the population. So as a magnitude of perspective, 23% of people 65 to 85 live alone. That goes up to 41% when you look at people 85 and over. Compared to the population under 65, sort of between the ages of 35 to 65, we're less than 10% live alone. So when you're socially isolating in your own home, it looks different when you have a partner to talk to or kids to talk to versus you have nobody to talk to. And so I think we have to be sensitive to the impact of that. And again, this is something, the impact of which is going to build over time. You're not going to notice it week 1, week 2 so much, but as the weeks become months, I think we're going to have to recognize the profoundness of that impact is disproportionate on seniors because they are disproportionately likely to live alone. And then health status. So COVID-19 response looks different depending on your health status as a senior. So if you're 65 or even 90 and you're robust and you're living independently and you can perform all your activities of daily living and your independent activities of daily living on your own, and you're living with your spouse and you have sufficient income, that looks one way. It looks not that unsimilar to many of the rest of us and how we're responding to COVID-19. But if you are like the majority of seniors, certainly over the age of 85, you need some help with your activities of daily living and perhaps even with your independent activities of daily living. And so you're now going to feel an impact. And certainly Marissa, and I suspect others, will talk about home care as well, and the availability of home care and the impact of COVID-19 on the delivery of those home care services are certainly going to have an impact on some seniors. It is also going to have an impact in a mental health impact for some seniors, as it really does dawn on them just how vulnerable they are when they need some help for their activities of daily living. They may not have appreciated it when they were getting the steady flow of home care, but as it became apparent that there might be some challenges to having that continue, I think there might have been an undercurrent of anxiety, additional anxiety amongst some seniors to recognize how vulnerable they're going to be living alone without that ability to come in and help. Although to the best of my knowledge, we didn't see that big an impact. Certainly here in British Columbia, we fortunately did not see an impact on home care services for seniors living at home. And then certainly those who are in assisted and in living and in the long-term care system. So for them, the economic challenges aren't profound, but the other challenges have been profound. Number one, the fear, but also the inability to visit with family members, which is still the state of events here in British Columbia, and I think in every other province to date. Hopefully we will find a way to reintroduce some capacity for family visits in a way that's safe, that over the next year can allow some of that connection to happen that's been lost over the last couple of months. And so that has had a profound effect. And the family members of those who are living in long-term care and assisted living. And they will be profoundly affected, I think, on two fronts: their inability to visit their loved one, and also what they are hearing and seeing and learning about what is happening in parts of our long-term care system. And I think it is important to acknowledge and understand that many care homes have responded with no outbreak of COVID-19. And some that have had outbreaks of COVID-19 have, certainly here in British Columbia, in the last month or so, have been able to swiftly and quickly contain that outbreak. And I think it's important, and Gudrun talked about this when we went out and surveyed residents in long-term care pre-COVID-19, that while many of them, first of all, do not want to be there, and while many of them do not feel it's home-like and do not receive the kinds of things they want to receive, many do as well. And I found it interesting when we went out and surveyed all of our care homes, and it was I don't think it's been done on this magnitude in any other province, where every single publicly funded care home, every single resident, and every single family member was surveyed, and surveyed by my office, so independently of the care home and the health authority. And literally 50% said, you know, it's pretty good here, and 50% said it's not very good here. And many of those people were in the same care home. And so we have to appreciate and understand that your experience in a long-term care facility is linked to a number of things. Your expectations and your experiences before you went into that long-term care home, and your health status in that long-term care home. So not surprisingly, levels of dissatisfaction rose as levels of complexity rose. So the more help you needed, the less satisfied you were. The less help you needed, the more satisfied you were. And so I think that speaks to some of the fault lines that have been very publicly revealed now around our staffing levels and staffing models that we have in long-term care throughout Canada. So those folks have a different experience in COVID-19. So what are the major challenges that we have? Certainly, I do want to start at the income level. So there's no doubt that for about a third, maybe 40% of Canadian seniors, income is a problem. There are many seniors who have sufficient income, arguably more than sufficient income. But we can't forget, and one of the measures that I use is the GIS measure. So if a senior is on GIS, they have a pretty low income, and it's linked to their...
Ms. McKenzie, I'm sorry, if you could wrap it up very soon.
Okay. So I think we need to look at that. I think that when we look at long-term care, I think we have to, I think others have spoken to the need to the things we need to do, and home care, because again, about 20% of people could live in the community if we had a better home care system. But in wrapping up, I also want to talk about the silver lining that I have seen in all of this, particularly here in British Columbia, and that has been the outpouring of support for seniors that we have seen, I believe, across Canada and absolutely here in British Columbia. And to put it in perspective, we opened up a 211, call if you need help, call if you want to volunteer. And the lines crashed with thousands of people calling in to volunteer to help seniors, as well as in order to help seniors. And so in the last 7 weeks, volunteers in BC have delivered over 54,000 services. Now there's many more. This is just through this one program. 36,000 virtual visits, that kind. So
wrap up, please.
So I think we need to look at building on this great, what I think is repository of desire from Canadians to make things better for British Columbia, or for seniors in Canada as well as British Columbia. So thank you.
Thank you. We go now to the Canadian Association for Long-Term Care. Ms. Jody Hall, Chair, please go ahead.
Thank you.
Merci de présenter ce soir. Je vais me laisser faire ma présentation. Là, est-ce que vous m'entendez bien?
I can hear you well, except that now I'm on the... I haven't changed my channel, but I'm getting the French translation.
Yeah.
I think I'm experiencing that as well. I'm sorry.
Yeah. So we'll just kind of sort that out. Can we just check that we're getting the proper translation on the English?
Are you getting English? Are you getting English now? This is the English channel.
And we're still good on the French channel? Looks like we're still good on the French channel. So I'll, Ms. Hall, I'll start you over, and please go ahead. Thank you.
Thank you very much. And once again, thank you for the opportunity to speak to the committee this evening. The Canadian Association for Long-Term Care is the leading voice for quality care in Canada, and our members deliver publicly funded healthcare services to seniors right across the country. I would like to start by acknowledging the seniors who have died of COVID-19. Our hearts are with those families, and I'm sure that you all join me in extending the deepest condolences to them. I also would like to take this opportunity to thank our frontline healthcare providers who have worked tirelessly with great compassion to deliver the care that's been required. As we reflect on COVID-19, we will take the time to understand what could have been done differently, but we believe that the impact of COVID-19 and long-term care homes could have been mitigated if governments had been proactive in supporting the sector during prior to this outbreak. Some of the challenges that I will be discussing today have been exacerbated by COVID-19, but really they represent systemic issues that our members have been raising for many years. I want to be clear that all types of homes have been affected by COVID-19, and each have had a different type of experience. This has been an extraordinarily difficult time and painful time for everyone involved, including residents and families, the frontline staff, but those who operate long-term care homes as well. And we just ask that the efforts of a nation continue to focus on rallying and supporting those in long-term care homes. The differences in experience with the virus have been based on a range of factors. So these factors have included infrastructure, the staffing situation in the homes, both pre-outbreak and during, and how rapidly the homes have been able to access personal protective equipment and staffing support when they really needed that assistance. In the early days of the pandemic, testing, the ability to cohort the residents, and infection control measures were focused on seniors and caregivers who showed symptoms. Infection control experts and public health scientists now understand that asymptomatic carriers are highly contagious and that the incubation period for COVID-19 is far longer than other viruses. So as a result, homes that were affected early by the virus seem to have been hit the hardest. I'd also like to clarify some misconceptions. Any and all care that is provided in long-term care homes, whether that care is provided by a doctor or a nurse or another type of healthcare provider, that is covered by provincial governments. So each province regulates long-term care just a bit different, but generally the homes receive a funding envelope for care, for programming, and for staffing. So in Ontario, for example, the governments fund all long-term care homes with highly prescriptive expenditures, which are audited through the government departments that oversee them. And they are reported to, those findings of those audits are always reported back to government. So every dollar that is allotted to nursing, to personal care, and to food budgets that are specifically earmarked, if there is any dollars that are left over in those envelopes, they have to be returned back to the provincial government. There is no profit on any of these funding envelopes. So in other areas of operation, the staffing levels are highly prescribed, and the funding model is extremely complex. It's highly prescriptive, it's tightly regulated, and it is monitored on a regular basis by each provincial government. So I would now like to speak to one of those systemic issues that we have noted as what we feel has been an exacerbating factor to COVID-19. Many older, and the first one is infrastructure. Many older long-term care homes have 3 and 4 bed wards. They do not have private rooms, and it makes it a challenge to implement cohorting and isolation measures. They generally have narrower hallways, And there's only one centralized dining room in the majority of homes that makes it much harder to socially distance residents appropriately. The Public Health Agency of Canada released an interim guidance document on infection control for long-term care homes. And some of the guidelines, such as restrictions to certain work zones and the use of single rooms for certain types of care, are almost impossible for homes to implement across the board, especially in these older facilities. Any existing outbreak management plan that these older homes have, including the isolation of asymptomatic residents, is really hindered by inadequate space and layout availability. And we can see just how devastating it is to have how shared rooms can be in an outbreak. So we know that there are at least 400 long-term care homes across the country that require updating in some form of modernization. It is imperative that the federal government support this sector by providing access to existing federal infrastructure funding. And there are many ways that this could be administered. And we also have noted that Minister McKenna recently spoke about financial support for shovel-ready projects in the post-pandemic stimulus package. And these projects indeed are shovel-ready, and we certainly could move forward quickly with federal support. The other systemic issue that I would like to raise is in regards to health human resources. This is a challenge that is facing this sector and is an ongoing, almost at crisis level across the country. Attracting and retaining individuals for a career in senior care has become increasingly challenging, especially when preparing for the aging demographic transition that we're experiencing right across the country. And we're caring for individuals that have multiple and complex conditions, much more so than what we would have seen in the past. We are asking for a health human resources strategy for the long-term care sector that is very much desperately needed, and it needs to focus on the right number, the right mix, the geographic distribution of providers, as well as an appropriate setting for providers to deliver the care in. Through the leadership of the federal government, there must be collaboration with the provinces and the territories and the long-term care sector to develop and implement a pan-Canadian health and human resources strategy. So in closing, there are systematic challenges that the sector has been grappling with for many years, which we have identified. And this really has been part of the exacerbation, or been fully exacerbated through the event of COVID-19. We have asked before, and we are asking again, that the federal government provide assistance to the sector to ensure that seniors have the housing and the care that they need, not just in a time of crisis, but every day. So I thank you for giving me this opportunity to speak, and I certainly look forward to questions. Mr. Chair, I seem to have lost audio. I'm sorry.
Sorry, the problem was my end.
Oh, perfect.
It's not that unusual. Thank you. And Ms. Armstrong, or is it Dr. Armstrong, if you would go ahead. 10 minutes, please.
There, am I unmuted now?
Yes.
Great. Thank you for the opportunity to appear on this critical issue. In the 1980s, the Ontario Pay Equity Commission asked me to study the health sector to see who would be missing from the legislation, a request that began my research into long-term residential care, or what are most commonly called nursing homes. Most recently, I've been the principal investigator on a 10-year interdisciplinary project on reimagining long-term residential care, an international study of promising practices. This research took international interdisciplinary teams made up of mainly senior scholars into nursing homes in 6 countries: Germany, Norway, Sweden, the UK, the US, and Canada. We observed, interviewed, and reflected together on what we saw and heard over a week-long span we spent in each of these homes. In this and in a number of other related projects, we've confirmed our central assumptions I want to set out here. First, we need nursing homes now and in the future for those who require 24-hour care. Such care cannot be provided in private homes, not only because many people do not have homes, or at least homes suitable for such care, but also because the care required is skilled and demanding. Your grandmother and mine never provided this kind of care because few people lived into old age and even fewer lived with the kinds of conditions and technologies required today. And of course, it is primarily women, unpaid for the work, who provide care at home now, often to the detriment of their health now and in the future. We need to plan for more and more accessible nursing homes where 24-hour care is provided. Second, the conditions of work are the conditions of care. These conditions certainly include adequate staffing in terms of numbers, composition, training, and continuity. These conditions also include pay and benefits, especially paid sick leave, and decent terms of employment, such as hours of work and shift length, as well as choices about them. And the conditions involve equipment that goes well beyond the personal protective equipment that has appropriately received so much attention today. But it must include such things as lifts and carts when we think about the health and risk to residents and staff. But the conditions for care include much more than that. Reasonable autonomy, the time to provide the care that training and experience have taught workers to provide, and support for teams are critical conditions. Union protections, and especially the right to say no to unsafe conditions and to the violence that is far too common, are also essential conditions. Similarly, the physical structure of the home, as we've just heard, and its location shape care. And this is not a complete list of conditions that are necessary for care. We have to take all of them into account in planning for care, both during and after the pandemic. Otherwise, we will not have a labor force, as the OECD and the ILO recently made clear in their report in December. Third, these conditions have to take into account all those who live in, provide paid and unpaid work in, and visit in long-term residential care. Our research clearly shows that it is not only direct nursing care that is critical. While there has been recent media attention to cleaning in pandemic times, there has been virtually no discussion of the laundry and dietary services that are also particularly important now, but are always essential to care. Moreover, families do have much more than provide the hugs that have received so much media attention. They also fill gaps in other care work, as do the privately paid companions many families provide. Volunteers, too, make critical contributions to the social activities and the physical environment, contributions that are essential to care in long-term residences. In recent years, this unpaid work of families and volunteers, the paid work of non-staff, and the unpaid work of paid staff have all expanded to fill the gaps in care well before the pandemic. We need to address the gaps in care at the same time as we ensure that everyone who provides care has the training required. Fourth, this is skilled, gendered work. We've heard a great deal about the heroism of these workers, which may end up like Mother's Day, a one-day recognition. Pay equity legislation grew out of the research demonstrating there is a systemic discrimination in the labor force, discrimination that renders invisible and undervalues the skill, effort, responsibility, and working conditions involved in women's work. And this is definitely women's work, whether carried out by staff, contractors, families, or volunteers. More than 4 out of 5 of those employed in this sector are women, and a significant proportion are new to the country and or are racialized. There's a faulty assumption that this is work any woman can do by virtue of being a woman. The value of and the skills involved in the labor may be further undermined by the fact that this is mainly women looking after older women. I'm reminded of an interview I did with the human resources manager of a large home in Norway. I asked her what surprised her when she went into the home after working in their major media corporation. And she said, I couldn't believe how hard these women work. When I asked her what she would do if she was in charge of the country, she said, I'd pay these women what we pay the men on the oil rigs because these women work harder. We have to recognize this work. We have to support it as skilled, demanding work that carries considerable responsibility. And we have to do so not just now, but in the future. Fifth, context matters. We talk about promising practices in our research rather than best practices, because there are often multiple ways of making care conditions as good as they can be. We can learn from other countries and jurisdictions at the same time as we recognize that what works well in Toronto may not work well in rural Nova Scotia. Nevertheless, we can establish broad principles for setting conditions, and we must do so to protect workers, residents, families, and volunteers. Six, the search for profit does not lead to better quality care, greater efficiency, or more choice, nor do many of the practices taken from that sector. Indeed, such privatization can lead to the reverse. We have to ensure that our public money goes to care rather than to profit, and to democratic decision-making rather than shareholder decision-making. At the same time, we need standards for all homes and to make sure that those standards are practiced and enforced. Well, there are many other lessons we've learned that take me well over my 10 minutes. Let me end by saying that this all leads to the need for federal leadership, as many here have said today. And I would argue that it should be through legislation similar to and parallel to the Canada Health Act, legislation that provides conditional funding based on evidence the principles and criteria are followed. We have a host of research and commissions that provide enough evidence and advice to move forward quickly. However, in doing so, we need to ensure that the voices of those who live in, provide paid and unpaid work in, and visit in long-term residential care are heard. And we must ensure that nursing homes are not only safe and accessible, but also organized, funded, and designed to make life worth living for all of those who live in, work in, and visit long-term residential care. Thank you, and I'd be happy to answer any questions.
Thank you. We'll start our rounds of questions now. We'll do 3 rounds. We'll start with Ms. Jansen. I would also like to remind everyone to try to remember that our terms of reference for these meetings are solely to receive evidence relating to the government response to the COVID-19 pandemic. Ms. Jansen, please go ahead, 6 minutes.
Yes. First of all, I want to thank everybody for being here. Both Pat and Ms. McKenzie, you both did some amazing work on reports. So I thought maybe I'd start with Ms. Armstrong. In your report about reimagining long-term care, in our committee, we've been hearing from many witnesses, and a number of them have made the assertion that public long-term care facilities have performed far better than private during the pandemic. Ms. Langhoff just suggested in her presentation that phasing out private long-term facilities is the fix that we need. Whereas I was reading your report and I thought it revealed that the issue is far more nuanced than just saying, if the government were running these facilities, this never would have happened. So clearly, one of the major challenges in the beginning was the scarcity of PPE and the need to ration PPE. So in your estimation, what grade would you give the Public Health Agency of Canada on their level of pandemic preparedness, especially with regards to PPE availability and distribution?
Well, am I unmuted? Yes.
No, you're good.
Yes. I think it is complicated, and I think, as several people have said, we will perhaps not know how complicated until this is all over. But yes, obviously, there wasn't enough preparedness in spite of what we saw in the SARS Commission's report that did say we should stockpile for a future pandemic. Although it has to be said that in the SARS report, the emphasis is, in all the SARS reports, the emphasis were on hospitals And that has been one of the problems, is not only that we didn't have enough and that the Public Health Agency didn't stockpile enough, but that when those services were available, that equipment was available, it went first to hospitals, and the primacy was placed on hospitals.
Yeah. Okay, now in your report, you make a number of short-term and long-term recommendations at the end of your report, which I very much appreciated. And of those recommendations, which ones are your top three, the three that would have made the most difference in protecting seniors in long-term care across Canada during this pandemic?
Staffing and the conditions of work. They have to be at the top. And as we look at what's happening, and as we heard about BC in terms of the strategies that were taken early to address this, they're about staffing. And we've known for a very long time that we need more staff. I can't tell you how many times we've been told there are not enough hands.
Okay,
and if I could say one more thing about, I've been just talking to our partner in in Norway, and they have had very few deaths in the Norwegian nursing homes. And one of the factors there, he said, was that the proportion of RNs on staff is significantly higher than anywhere else.
I do understand that here in BC, and maybe Ms. McKenzie could speak to it, that staff was basically moved from facility to facility. And I thought that was really interesting, how staff is using, obviously, because we were rationing PPE, they're using the same equipment as they move from patient to patient and from facility to facility. I know in my industry, everybody's required, as they come into a vegetable facility, they have to put on an outfit, which they take off again at the end. So you wonder how much could have been done had we had those sorts of PPE available. And I was just wondering, in regards to your billion reasons to care, I loved your title there. I was struck by the statistics that you share regarding the difference between for-profit and not-for-profit long-term care facilities. As I mentioned, people are making the bold assertion that public facilities have performed far better than private. And I know just down the road here from me, there's a private care home actually banned provincial healthcare workers who are being sent to his facility by the local regional health authority because they were only given 2 sets of gloves and 2 masks to use for the month. So again, how important is the factor of the PPE as opposed to public or private? Because we have some amazing facilities here. Look at the dementia village that we have here in Langley. It's absolutely amazing facility, private, but wonderful option for seniors.
Well, first of all, when you look at so far in British Columbia, there is quite a difference in probability of an outbreak with a contracted care home versus health authority owned and operated care home. That's actually of the many, that is a very clear pattern that's established. It's I think 8% of the outbreaks are in owned and operated sites, and yet owned and operated are 37% of the sites. So there is quite a difference here. Now, the PPE issue, I think it is complicated because part of it is the lack of understanding of appropriate use of PPE. And this is something where I think strong clinical leadership can help in a care home setting. And it's not clear, when we get all the data and we can sort all through it and we look for the patterns around that strong clinical leadership. And I think for me, one of the litmus tests is when I hear care homes talk about N95 masks and the care home has no outbreak. You don't use an N95 mask in a situation where there is no outbreak. And so I think there's the issue of the supply writ large, then the appropriateness of the use of PPE, irrespective of the supply. And I think it all, when we talk about we weren't prepared, here is my observation, and I've spent 20 years in delivering in both home care and long-term care, is that we completely underestimated, for want of a better term, the freak out factor. So we are accustomed to outbreaks in long-term care. We handle them every year. We had 185 of them last year in British Columbia. We have protocols, we notify. But that's influenza, norovirus. We completely underestimated that when it was COVID-19, that we needed and this is where I think British Columbia was able, because we had the first outbreak, and perhaps because the first outbreak, the care home wasn't able to respond, that public health got in there and saw how quickly they needed to get in there and take control, and then were able to keep doing that. And I think that that is what has happened in British Columbia. It is the public health going in right away. And I think that when I look at what has happened in other parts of the country, that wasn't as quick off the ground, in part because we had the first outbreak here.
So I'm wondering.
Thank you, Ms. Stanton. We go now to Mr. Kilroy. Mr. Kilroy, please, 6 minutes.
Thank you, Mr. Chair, and hello, colleagues. Before I begin with my line of questioning, I just want to say it's a real privilege for me to hear from the witnesses today, for all of us to hear from the witnesses today. In my riding of Cape Breton-Canso, we have a large seniors population, and I keep them in mind every day. And through this pandemic, I've seen just how much citizens throughout the riding have come together to support seniors in our communities during these challenging times. And I want to thank each of you for the work you're doing in this regard. My question is for Dr. Armstrong, and this has been referenced, but you wrote a report that identified staffing issues and shortages of staffing and low wages for healthcare workers and long-term care facilities that have contributed to the spread of COVID-19. And we know the spread of the illness, including the common flu, have been known to spread quickly throughout long-term care homes, even before COVID-19. Now, in your research, what solutions have you concluded can address these staffing issues and can prevent the spread of the communicable diseases? And can you talk a little bit, I think you've alluded to this, but the best practices that you've been able to identify that long-term healthcare facility administrators should be aware of? So my question is to Dr. Armstrong. Thank you.
Oops, I'm on, I guess. Well, staffing has been identified in report after report after report, not just in terms of numbers, but also in terms of training and distribution. I think if we had had adequate staffing levels to start with, we wouldn't have had the kind of desperation that we've seen. If we'd had full-time jobs, we wouldn't have to be introducing the kinds of practices that were introduced in BC, because those would already be what was happening in homes. If we had surge capacity within the homes in terms of the labor force and in terms of the physical space, then we wouldn't be having this crisis either, I don't think. And we've known this for a long time. And if we don't learn the lesson from this, then I think that we are going to be in worse trouble in the future, which is one of the reasons we want to talk about the future as well as now. But we have lots of evidence that 20 years ago, they were saying 4.1 hours of nursing care per resident per day was essential. And that was before we had residents with the kind of level of complication that they need now. Charlene Harrington, who's one of the biggest experts in the US on this issue and who I was talking to this week, she's part of our research team, said that they're now saying it should be 4.9 hours per resident per day, given the level of acuity that is the case in most homes in Canada. And we don't have any province that even comes, or territory that comes even close to that. That's in regular times.
In regular times, absolutely, and that was probably 20 years ago, as you mentioned. Just to stay with you for a second, you brought up and again throughout the many witnesses that we've had to come to talk to the committee on various topics within COVID, there seems to be a bit of a common thread around greater federal oversight in a variety of ways, and you referenced that here in this session. I'm wondering, can you elaborate a little bit more as to what that looks like to you?
In terms of the federal role, I think they need to put in money, but I think it needs to be money with conditions, and I think that it could be in a parallel piece of legislation to the Canada Health Act. I don't want to open the Canada Health Act. And I also think that what is in the Canada Health Act is a brilliant piece of legislation because it sets out the principles while allowing each jurisdiction to adapt those principles within their own jurisdiction, so that it gives us both. But the principles are somewhat different, I think, in terms of long-term care. And we have a different kind of labor force. I certainly think it needs to include a national labor force strategy, but that isn't the labor force that's addressed in the Canada Health Act. And they do talk about reasonable compensation, but they don't talk about the principles don't address some of the other issues that have been raised today, I think, and that have been raised over and over again. But I think we have enough information now, enough evidence now that we could set out those principles. And especially if we consult the kind of people we've been hearing should be consulted today.
Thank you, Dr. Armstrong. How much time do I have, Mr. Chair?
50 seconds.
50 seconds. I'll try to get one in here for Ms. McKenzie. A few weeks back, I read that BC had announced more supports for seniors and caregivers during COVID-19, and in addition to the funding provided by the feds through local United Way organizations and the New Horizons Seniors Program we announced in early April. Now that the provincial funding has been out there for about 3 weeks, maybe close to a month, I'm just interested from your perspective of how what are you hearing in terms of how this has benefited seniors, and has it been difficult for them to access their support? And this could be something that I could have easily asked people from other provinces as well in terms of provincial measures, federal measures, but in this case, the provincial measures. I'm curious as to what you're hearing on the ground.
Well, the funding that you're speaking of went to the BC 211 program over the last 7 weeks. And so that's where I was highlighting 54,000, those sorts of services. So what it showed us was obviously, number one, make it easy to get the service. That was the beauty of the 211 number. There's not a lot of digits to remember. Number two, harness the energy and capacity of volunteers that want to help, right? That was a key part of the program. And get them connected with those seniors, responding quickly to things like, I need groceries, I need meals delivered, I'm getting lonely, I need somebody to talk to. So from that perspective of the issues created in COVID-19, I think that was an effective way, and it got out there fast. And full credit to the BC provincial government for doing that, and partnering with the United Way and with BC 211, which is interlinked with United Way, and that's a network across the country. And I think that the federal government signaled that as well with what they did. So I think it can be highly effective. It certainly has connected a lot of seniors with services that they needed, not medical services, but important.
No. Thank you, Mr.
Great to hear. Thank you.
We go now to
Mr. Thériault.
6 minutes, please.
You have 6 minutes. Thank you very much, Mr. Chair. I would like to thank all witnesses for their testimonies today. We need to find solutions. I would like to first ask a question to Mr. Brunet. Your testimony was quite interesting. You are known not to be complacent, and I appreciate that quality. On March 13th, Quebec was the first one to declare a state of emergency, and there were only 17 cases, no death. 2 months later, we now have more than 40,000 cases of infection and more than 3,200 deaths. Most witnesses we've heard told us that the situation was exacerbated by what others called the weaknesses of our healthcare system, and stated that one of the reasons was the underfunding of the system. We talked about having consistent rules from one coast to the next. Healthcare is a provincial jurisdiction. You said that faced with a nationalization of long-term care, you had some reservation. You talked about minimum standards instead, and I would like to hear you on that. If you could please describe to us what the metrics would be, what the parameters would be of such a legislation. Thank you. You are right. For 45 years, we've attended numerous parliamentary committees. We've been part of public hearings and such, talking about long-term care. And today, we are at the same place in terms of results. Long-term care is an everyday issue. We need concrete action in the field. I have 25 years of experience as an advocate in the healthcare system. And despite all of the studies, what I can tell you is that it's not a matter of public versus private. I've seen miracles in the public field and in the private sector as well, and I've seen horror stories in both cases too. But the difference lies in the people who are managing these places, uniting people together, people, healthcare workers, etc. When all of these people were at the same table, there were results and there were few complaints. I have 25 years experience, and so I've seen a lot of different cases. The difference has to do with the people running those facilities. This is what I see. I'm quite interested in the legislation you are suggesting. On April 25th, in an interview, you said that you've prepared a bill, and I would like to know how this could become a solution in Quebec. Well, for 20 years, we've been documenting everything, operating the facilities, how to supervise the staff. We've been talking a lot about the staff, but you need supervision. There are people who do not have a lot of training, needs to be supervised, need to be guided. So our bill states that we need to have minimum services described for different types of facilities, and there will be conditions. Whether or not that's private or public, you would not be able to operate under certain conditions. There would need to be follow-ups. We've told the government time and again that if there is no follow-up after measures are implemented, we might think we are safe. We might give licenses to people to operate facilities, but there could be problems. Right now, the solution might be enough funding every year. There are health transfers, and they've been cut by 3 to 6% every year. Networks are trying to make do with what they have. With the pandemic we are facing right now, this is a health crisis. Some facilities are infected, and the government has been investing in different programs. For $100, 33 cents only go to healthcare. going to our angels, our guardian angels. So I believe we must do more. Yes, of course. I had lunch with Philippe Couillard, the former Premier of Quebec, who said, I'm announcing 20 millions for my region for the CHSLD. And so I went to such a facility and I asked, did the money arrive? And there was some funding, but there were a lot of problems with red tape. We want people to get the money. At the Granby Zoo, staff get $16 an hour, but our staff get $12 an hour in healthcare facilities. These are shocking examples. We need those shocking examples. We have the same problem in Quebec, but the problem is even worse at the federal level. Well, what you are saying is that there must be money invested in the front lines instead of trying to put in place programs from coast to coast, which come with administrative costs. There needs to be monitoring, for example, and there are numerous public servants in the Department of Health who are not in the front lines and they are costing money. There is an accreditation organization in Canada. They are supervising everything, but they do not see the food. They do not hear what's being said in the field. The accreditation for long-term care facilities. Well, there are standards to be followed and implemented, but if there is no follow-up, that is a problem. In Quebec, there are volunteers doing visits in the field, and because of Mr. Barrette, the power to speak with people in the field has been restricted. So the bodies responsible for accreditation lead to very little results. There is a lot of bureaucratic work, but there's little done in the field, on the ground. We should go into the field and taste the food that is being served, for example. Do I still have time? Yes. I wanted to ask you, Mr. Thériault.
Time, but I think I gave you extra.
Je trouvais ça très agréable.
I thought it was quite pleasant. I was having a good time.
Thank you, Mr. Chair, and thank you to the witnesses all for being here. Dr. Armstrong, you recently co-authored a report entitled Reimagining Long-Term Residential Care in the COVID-19 Crisis, which recommended stopping privatization and ensuring nonprofit ownership of long-term care facilities. Can you outline for us why you made those recommendations?
Well, I think that there's a research indicating patterns. And of course, there are some good for-profit homes. There are some bad municipal homes even, or not-for-profit homes. But the pattern is clear that there tends to be lower staffing in a for-profit. There tends to be more reliance on part-time and casual employees in for-profit. There are patterns of more ulcers, more transfers to hospitals, more falls. There are a whole host of patterns that are much more common in for-profit homes than in non-profit homes. And I should be clear that we said nonprofit, so that isn't talking about the government taking over all the homes. I'm talking about taking the profit out of care. But I don't see any reason to put the money into profit when we're not particularly getting a benefit out of it. And in fact, it may be the reverse. So why isn't that money going to care?
Thank you. Ms. McKenzie, if I can turn to you on the same subject, you put out a February 20 report that found that the province's for-profit long-term care home operators, while making profits, are shortchanging seniors of more than 200,000 funded care hours per year. Your report found that nonprofit operators spent $10,000 more per resident per year than for-profit operators, and delivered 80,000 additional hours of care beyond what they were funded to provide. It also found that under the current funding scheme, for-profit operators spent far less on care aides and other frontline staff than their not-for-profit counterparts. Would you also endorse Dr. Armstrong's view that we should be putting more money into the nonprofit sector as opposed to the for-profit private one?
Well, I think what the report demonstrated was we don't have the proper financial incentives or oversights. And you could argue, Mr. Davies, that if we get it aligned, that being a for-profit operator will be of marginal value. But I can't speak for Ontario. I know Jody was talking about the way the money is managed. That's not the way it's done here in British Columbia. So we give a lump sum of payment to a contracted provider, and we come up with that lump sum by saying you should spend this much on this, that, and the next thing. And they do provide statements that say, here is what we spent on this, that, and the next thing. And we look at that, but we don't do anything with it. So the classic example is around wages. So in British Columbia, all care home operators are funded to provide industry standard wage levels. So they are provided enough to pay care aides at the industry standard. But whatever they pay them less than that, they get to keep. And that's the problem. So the question is, there's things we could do quickly. And what we could remedy quickly is certainly the money we're giving you to pay wages for, we call them care aides in British Columbia, personal support workers, whatever, you have to pay that. And if you don't pay it, you have to give it back. And what we pay you for the nurse, you have to pay. And if you don't, you have to give it back. And so we take away the incentive to, and by that, we take away the profit, right? We take away the motive for making the profit. So, and there was a very clear pattern that showed, and as Pat has said, it's a pattern, which means there are exceptions to the pattern. So yes, there will be good performers, or as economists would say, good actors in the private field, and there will be bad actors in the not-for-profit field.
Good. If I could, I'm sorry, but limited time, I'd like to focus on just quickly. Ms. McKenzie, you're obviously British Columbia's seniors advocate. I note that Canada does not have a federal or national seniors advocate. Would that be something you'd recommend the federal government establish?
I think that they can certainly look at it. I think the challenge here that's been identified is a number of these issues are provincial. So what is the role of the federal government around this? Prescriptiveness is going to be limited, but leadership will be able to be there. The federal government does give money to provinces and can put strings on that money. And so those are levers, those are our public policy levers available to the federal government, even within the confines of the Constitution and the BNA Act.
Well, thank you. You've anticipated where I'm going to go. So back to you, Dr. Armstrong. There is this question of what the federal role is. Some of us are calling for binding national standards with respect to minimum standards of care, ratios, etc., and federal leadership. You've indicated one particular model being a piece of legislation analogous to the Canada Health Act, but not the Canada Health Act. I understand. What's your view on what the federal government should do in terms of long-term care?
Well, we set out that in the report, I think, to some extent. It certainly should establish the conditions of work, which would include things like staffing and wages and benefits. Obviously, you don't set out the specifics, but you set out the standards and how you have to, for example, keep to the industry standards in those areas. And minimum staffing levels are absolutely critical. And also some notion about the appropriateness of the staffing levels, even if those are minimum. I mean, I always worried that the minimums will become maximums, but I think that if there was...
Dr. Armstrong, could I just interrupt and just shape you in one particular aspect? So I'm curious about your views on like the Canada Health Act has 5 principles, including universal access and
Right.
public administration. Would that be something that would you take those concepts and advise those to be applied in terms of long-term care?
Yes, if we understand access is, and as it says in the Canada Health Act, there's a broader definition of access of not simply financial, although financial's there, but it also includes actually having the facilities there. We haven't pursued that a lot, but yes, I would certainly include access, uniform terms and conditions, perhaps, comprehensive. It's interesting, it's the only place in the Canada Health Act where they get detailed and talk to you about what should be included. And we charge for accommodation in every jurisdiction in Canada, so we exclude the food and in some places the laundry, and we include some of those things that we heard about, talked about in terms of a plan in Quebec, because I would argue that food and laundry are absolutely critical to care. So we have to talk about what would be included in those services as well.
Thank you, Mr. Davies.
Thank you.
That ends round 1. We start now round 2 with Mr. General. Mr. General, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here today. I do want to talk a little bit about some of the Ms. McKenzie and Ms. Lennox touched on with regards to the degree at which investments will be impacted by the senior and retired population. Thinking mostly that it's this. Obviously, the government's come forward with a $300 credit, if you will, but I still get a number of emails on that long-term impact of what this would really mean for those individuals. Maybe Ms. Lennox, since it's been probably about 2 hours since your initial presentation, maybe I'll allow you to kind of kick us off here with announcing or talk about some of that, and then over to Ms. McKenzie to also provide some of that feedback. Maybe we'll start with Ms. McKenzie. It looks like Ms. Lennox might not be there.
Okay, when you let me know when her microphone unmutes and I'll stop talking. But this is the other shoe that really hasn't dropped yet, and we don't know what the impact is going to be until we see what's really going to happen to the markets over time. You can't really tell now. It's going to be a year from now. And so when we look at where seniors are getting their income, these would be seniors who have income in addition to their basic government pensions. A lot of them are getting them from dividend income. And so what's the impact of that? What is going to be the impact on some private pension plans? Are they going to reduce the pensions because their investments have made them unable to make those payouts? We don't know that yet, but I think we have to remember that that is still coming. And the ability for middle-class seniors, because you've heard me talk a lot about the poverty amongst seniors, but there's also a group of middle-class seniors. But we need them to have sufficient income because they're also paying for a lot of their healthcare needs. I agree with Pat. I think, the Canada Health Act is great and has some challenges. A lot of health services that probably everyone on this Zoom call doesn't even think about, because we can do them all ourselves, become health services for people in the community, and they have to pay people to help them, and they need money to do that. So we can't forget that piece of it. But I think certainly initiatives around reducing the withdrawal amounts for, I've lost the call, I think those are all helpful for now, and we'll have to wait and see what happens to the markets. So
is there anything specific then, Ms. McKenzie?
Excuse me, Matt. Ms. Lennox has been asked to drop and rejoin. So if you want to ask her a question, we'll suspend for a minute or two and let that happen. So
we can keep it, if it's okay, we can keep going. Then we don't have to meet.
Okay, fair enough. As you please. Yeah. Go ahead.
Sure. So Ms. McKenzie, when it comes to, is there any work then being done in terms of what that looks like what the ask will be in terms of helping to protect these seniors. And because I think of the ones that have emailed me, this was their plan for retirement didn't impact. This wasn't part of the plan for retirement. So I guess just trying to find what that ask will be, and if it's fair to say, okay, well, we'll look at what the markets do, but I think if there's an ask in place, we'd love to be able to consider that too as this committee continues.
Well, I think the ask would be to look at the overall economic impact on a group of people who have now lost the ability to in any way change the trajectory of their income. They have retired. They can't build, they can't add to their savings any longer. They're drawing on their savings. And I really, it's not a finance committee, but I don't know what markets are going to look like in a year from now. They may completely recover. You've heard this. Is it a V? Is it a U? Is it an L? And those provide very different outcomes and the degree of the impact. I think that making sure that people don't make rash decisions right now is important. And I think looking at measures that allow people to not have to cash in if they aren't required because markets are exceptionally low. And I also think allowing for some capacity of capital withdrawals to shore up some expenses during this time may also be helpful as well. But I think there's another side to this that we'll see what it looks like when the markets settle and we see where we're at.
Thank you, Mr. General. We'll go now to Dr. Pawlowski. 5 minutes, please.
Thank you. I read somewhere someone describing a busy neighborhood bar, and I miss such things. But they described a busy neighborhood bar in terms of a place for transmission of disease, communicable diseases, being something akin to a wet bar in China. Now, there are different kinds of chronic care homes, and I would guess that depending on the kind of home, some have had more problems than others. And I think probably some homes in terms of spread of infectious diseases might also be akin to a wet bar in China. And Ms. Hall, I think, outlined some of those things. A lot of homes where there's 4 people to a room, narrow halls, one cafeteria. I might add a few other things: lower income residents, more seniors who are more elderly with more chronic care homes, less number of staff. And those are the ones where coronavirus is hit, that it really spread like wildfire. Am I right or wrong in saying that? Ms. Hall, maybe I can ask you since you're from the...
Yes, I mean, those are absolutely factors.
Madam Hall, please bring your microphone closer to your mouth, please. Thank you so much.
Sorry, is that helpful?
That's much better. Thank you so much, Madame.
Thank you. Yes, as I had outlined before, the overall condition of the infrastructure in homes, especially those older facilities, they were designed for a different generation, a different type of individual that required care. And so when we look to who we are caring for today, these are people with much more complex conditions than when these homes would have been built 20 to 30 years ago. And so the room configurations, the overall design and layout of the building does put people closer together. And so when we think about things like isolation, cohorting planning, those become very significant factors in the overall prevention efforts against COVID. We also have to remember that, from the beginning of this outbreak to where we are today, we have learned a tremendous amount, especially as it relates to asymptomatic transmission. When we look at the homes that have experienced the most significant outbreaks, that was a critical factor as well, as staff introduced that into the homes and didn't realize the extent of their illness.
Okay, now I think I maybe want to continue on with you, Ms. Hall, since you work with chronic care homes in general. I think Public Health Agency of Canada came out with recommendations as to safety standards, public health measures to protect the elderly in chronic care homes April 13th. Now, Quebec, I guess, declared a state of emergency March 13th. Certainly, it was mid to late March where we started to really implement those social distancing programs. So before April 13th, when Public Health Agency of Canada came out with those standards, what was in place beforehand? Did the provinces have safety measures, and were those being implemented in the homes before April 13th?
Yeah, I think that everyone became extremely aware of the situation in early March. Individual care homes, and certainly with the colleagues of mine across the country, the discussions were very active and robust as we worked to see what was happening internationally and starting to see the cases pop up in our own country. There's been many examples and case studies that we were taking and trying to share kind of between amongst ourselves as to what the strategies are that were needed going forward, and then also looking to the provincial governments who were starting to take action. That happened at different rates in different provinces, and that included when access to additional PPE, additional kind of guidance from the provincial public health departments were made available, and so there was a bit of a range of time. But that early access to appropriate personal protective equipment, better information, key information about asymptomatic transmission in particular, and as that symptom list began to grow, those were all factors for us.
Okay, I want to get one more quick question in. I think you said that the recommendations by the Public Health Agency of Canada to protect the elderly in chronic care homes, when it came to the worst homes, you couldn't implement those recommendations. Did I hear you right? Things like requiring isolation when there were all rooms contained up to 4 people. So do I have that right? That some of these recommendations were unrealistic and you couldn't be implemented in some homes?
That's correct. Our point was that there was a disconnect between some of the recommendations that were being made when you compare that to the reality on the ground and what could actually be operationalized.
And now did Public Health Agency...
We go now to Dr. Kitchen. Dr. Kitchen, go ahead. 5 minutes, please.
Thank you, Mr. Chair, and thank you everybody for being here and your presentations. It's greatly appreciated. And it was so nice to hear many of you talk about breaking things down about long-term care, because I think a lot of Canadians are missing that fact. They lump everything together when they don't understand all the factors. And I think Dr. Armstrong, you sort of said it really clearly when you talked about appropriate training with nursing, cleaning, laundry, dietary, volunteers, support staff, families. Those are things that have to be looked at. And so I appreciate that. Ms. McKenzie, you mentioned about the outpouring of support we've had for seniors because of this crisis. And I think it's fantastic that we see that. I'm wondering if you're hearing, if you're hearing that families are also stepping up in helping out, besides the volunteers that are helping out for other people, but are families stepping up? And I guess the lead to that, or the end to that, is, do you anticipate that being there when this crisis is over?
Well, I hope it's there. So the short answer is families are absolutely stepping up. So, and we saw that initially, and my office hears from folks all the time about, their sons, their daughters, their grandchildren, making sure they get the meals, et cetera, et cetera. So that is the silver lining in all of this, is that when the chips are down, Canadians have shown overwhelmingly they really care about our seniors. And so we have to build on that and leverage that now to get the needed improvements that we need, that a number of people have spoken about. And I think that, we will, in long-term care, I think that certainly we've seen families express their both their understanding of why they can't visit and their frustration that they can't visit. And I think that's also reassuring in the sense that there are a lot of family members out there visiting their loved ones in care homes. And then we also hear about how they visit other people in the care homes that don't have family members they don't live in the same city as their family members. So, I am hoping that we will sustain this when we are through this pandemic. And that this, the phrase I use is, my grandmother, my mother, myself, right? That people can see that they, yes, I do not want that for my loved one. I don't want that for me. And that if the will is there, the change will happen.
Thank you for that. Ms. Hall, you talked about two things you left us sort of with one was infrastructure and the other was health and human resources and how challenging that is. And in particular, when we're dealing with multiple complex situations, as we see with seniors, when I did my practice, basically the average lifespan for a male was 78 and for females was 80. And now we see that much longer. And now we're seeing issues of dementias. We're seeing Alzheimer's, anxieties, bipolar issues that we're seeing more and more of that are happening as we age. And so that training for people to actually deal with that, and you covered a lot of that when you talked about the tightly regulations that are needed to make certain that they're being followed, and they are being followed. And I'm just wondering to hear your comments on, last week, the Minister of Employment and Workforce Development stated that with respect to providing assistance in long-term care homes during the pandemic, and quote, we may create some kind of training so that people who aren't in these jobs now, maybe people who are at home and unemployed, can take a shortened version of this training and be able to perform the less complicated tasks that are required at these homes. I'm wondering how you see that impacting on all of those aspects as you've talked about.
Well, it certainly is critical that we have access to an appropriate workforce, and that has been an absolute.
Ms. Hall, could you speak into your mic, please?
Sorry about that. It is critical that we have access to an appropriate workforce. It does cause me pause to think about any particular mandate being given to a group who may not necessarily have a desire or an aptitude. Caring for frail elderly is work that requires someone with great compassion and skillful ability. And so, of course, if there are individuals amongst the population that are willing and open to receive that training, we would certainly welcome them as members of the workforce, but would be hesitant to see something that would be a forced program, if I can express it that way.
Assuming that they had the appropriate training for the level of skill that's needed.
That's correct, yes.
Thank you. Ms. Lennox, I appreciate your
I'm sorry, Dr.
comments.
Kitchen. Sorry, your time. I'm sorry, your time's up.
Oh, thank you.
It was going so well, I was kind of in a lull, but
I was hoping to get Ms. Lennox back into the conversation somehow.
Okay.
Yes. Anyway, thank you. And we go now to Ms. Sidhu. Ms. Sidhu, we have you have 5 minutes. Please go ahead.
Thank you, all the witnesses, for being here with us. My question is to Ms. McKenzie. British Columbia has reported 285 cases in long-term care homes and 74 deaths as a result of COVID-19. But Ontario reported more than 2,000 cases and more than 1,000 deaths from COVID-19 in their long-term care homes. So what BC is doing better? And can you talk about what you think, what are the best practices so other provinces can follow that?
Well, I think I've spoken at it and others have as well. So I think the reason we are seeing at this moment better outcomes in British Columbia is because of what we learned at the first outbreak at Lynn Valley. And I think the approach has been that first of all, we lowered the barrier to declare an outbreak on one case. The normal outbreak threshold is 2 cases, 1 laboratory confirmed. So that was first. We looked at staff equally as residents. I don't know how many people here have been in practice, but when I was in practice, we never looked at staff for influenza swabbing. We looked at residents. So that, I think, has helped. I think that public health, then, the minute the outbreak is declared, which is 1 confirmed case, either staff or residents, public health gets in there immediately and they give direction to the care home around all of the things that need to be done. So we talk about the cohorting, we talk about these other things. Now in British Columbia, 75% of our residents are actually in single rooms, and I think that is higher than other provinces. So I think that that has also helped us be able to manage the best practices that PHAC has recommended, that I think any infection control person would recommend. I think the recognition of the care staff as the vectors of transmission, the designation to one work site, which was done earlier, I think that has been helpful. I think if there's one area where we lagged a bit, and I would say everybody did, and Jody has talked about this, which is the testing of asymptomatic in an outbreak situation. I think we learned early on we weren't doing that because the evidence at that time was that the test was ineffective if you were asymptomatic. We now know that asymptomatic people both can shed the virus and can test positive for the virus. So we have started that best practice as well. So I think it's those things. Certainly the absolute quick SWAT-like intervention of public health at the very beginning, I think has been key to helping us.
And my next, thanks for that. My next question is for Dr. Armstrong. Canadian Anti-Fraud Centre put out a bulletin warning Canadians to watch out for scams associated with COVID-19. They warn that fraudsters want to profit from Canadians. As you know, people of all ages can be victims of fraud. Older people get targeted more than others. What more can be done working with the public health authorities to cut down on, eliminate the spread of misinformation? Any thought about that, Dr. Armstrong?
That's not.
Dr. Armstrong, you're.
I'm okay now. I think others might be better able to answer that question about fraud and misinformation than I am.
Anybody can talk about that because mostly sometimes as they can get seniors. That is, even though all ages can be victim, but the seniors are getting targeted.
For sure. I think that there's no question, as we've heard from a number of people, that the older you get, the more vulnerable you can be to many of these, not because you're not smart or capable, but because they take advantage of what might be areas where you don't have the expertise, like me in technology.
And one more thing, in your view, how has the pandemic impacted seniors' mental health and well-being?
Well, I think in terms of long-term residential care, both those who are inside, and Isabel was stressing this, both those who are inside and those who are outside the home, I think are suffering a great deal from fear, from isolation. Even if you're in a long-term care home, they suffer from isolation. I want to go back to something that Isabel was saying earlier about long-term care. We seem to see this as the worst option in terms of where people can get care. But I went to a resident council meeting here in Toronto as part of a study we were doing and asked them if there was anything better about being here than being at home. And they unanimously said, oh, yes, here we feel safe, but they were talking about safe in terms of getting things like their insulin. They had company and they had activities. So I think that we have to think about these places as good places to be when we're responding to this kind of issue.
Thank you, Ms. Sadu.
Thank you.
Monsieur Thériault, we go now.
Mr. Thériault. Thank you. Thank you, Mr. Chair. And thank you. Mr. Brunet, in one of the documents titled Other Forgotten People of COVID-19, and you signed this, you also speak to the issue of people who have mental health issues and who are hospitalized or housed in a public facility. What should be done? First of all, could you speak about this issue? What has to be done for these people so that they're able to receive adequate health care while being protected against COVID-19. What we've received as a complaint, we have over 2,000 users. We have 300 individual members for which we advocate, but what we're hearing from places where people are housed, people who have mental health issues, is that there's a lot of isolation, a lot of restrictions are being placed, but in places that could be better adapted, a lot of people are being locked down, locked in, and they've been victims. This is sad because many places, I'm thinking of Hippolyte Lafontaine and other places, these are empty places. They're old. Imagine people with mental health issues and they are locked up and quarantined even more because of COVID-19. So this creates a lot of issues around safety, violence, physical violence, emotions. I'm speaking of people who have mental health issues to start with, and they don't necessarily understand what's happening. So I would say that mainly the places, the physical places, don't allow, they're outmoded and they don't allow to care for these people. So this has been a huge challenge. Now, with regards to the long-term care homes in Quebec, there are two missions, one for care and one for a lifestyle. And so I think that we are not at all even close to the lifestyle mission statement. The families, the natural caregivers, what needs to be done as of today to try to quickly right this situation in today's current context? Well, it's difficult because we're in the middle of a pandemic. For over a year now, we've been suggesting to the government that we'd like to participate in recruiting to show that this is one of the most noble jobs in society, that is to take care of people that are ill, that are elderly, that require care and assistance. But right now, in a situation of a crisis, we're looking at people, there's no plan. They're asking for doctors, they're pleading for all kinds of help. We need to have a greater amount of people working. We need to have better supervision also. I said this earlier. And this is fundamental. I was listening to a colleague earlier from another province say that laundry costs, we've fought up until the Supreme Court so that the laundry costs would be free for people who are living in long-term care. Food. There are huge challenges, and we have spoken to different ministers, Minister of Health, Minister for Seniors, but politically speaking, I know that there are challenges, and we're not about to extend a hand to organizations such as ours. We also want to help, and we've been following this for a long time.
Mr. Thériault. We'll go now to Mr. Davies. Mr. Davies, 2 minutes and a half. Thank you.
Thank you, Ms. Langolf. This morning I participated in a webinar sponsored by the Canadian Federation of Nurses Unions with a number of speakers, and one was Dr. Samir Sinha. And according to him, he stated that long-term care is the largest form of care in the country, healthcare, that is not covered by the Canada Health Act. And I noticed one of your recommendations was to bring long-term care under the auspices of the Canada Health Act. Can you tell us why you think that would be a wise course of action?
All right, I think I'm unmuted now. The difficulty that we have is that there are 11 plus jurisdictions for the health conditions or for health transfers of money, and that many more differences of quality of care or details of the service that's provided to citizens because it's left up to provinces. Now, we're not suggesting that they're negligent. It's just that they have different priorities. And chances are, unless you provide a guidance with national standards that are clear and understandable across the board, it depends on where you live, whether or not you get decent
Pardon me,
service
Ms.
or not.
Langoff. Could you speak a little louder, please?
Sure. I'm trying to eat my microphone now. Is that better? I hope so.
It's somewhat better. Just speak louder might just help too.
Sure. So what happens is that it depends on where you live, whether or not you receive a service or not, which should not happen. It's a Canadian standard, ought to be consistent across the country.
Well, thank you, then, to Ms. Lennox. Picking up that point, according to TVA Nouvelle, almost half of Quebec's residential and long-term care facilities have not been inspected for more than 3 years. And a recent CBC News investigation found only 9 of Ontario's 626 long-term care facilities received a resident quality inspection in 2019. Ms. Lennox, you testified that you felt it was the duty of the federal government to, quote, make sure that this doesn't happen again. What is your advice to the committee on the proper role of the federal government in addressing long-term care?
So I think that the Canada Health Act is one tool that you can use in order to raise standards in long-term care. As Ms. Armstrong also mentioned, I think the other tool is to stand up, sort of its own legislation similar to the Canada Health Act, but specific to long-term institutional care or long-term medical home care. When you think about the people that are receiving this kind of care, though, they are requiring the highest levels of institutional care and long-term care, and it should really be treated no differently as a hospital. And so, I guess I would suggest that the federal government need to revisit its funding formula when it comes to providing this kind of care, and that we need to raise the standards and make sure that they're consistent across provinces.
Thank you, Mr. Davies. We go now to, that brings round 2 to a close. We'll start round 3 with Mr. Weber. Mr. Weber, please go ahead, 5 minutes.
Oh, 5 minutes, wonderful. Thank you, Mr. Chair. My first question to Ms. Lennox. The Government of Canada has announced that a select group of seniors will receive $500 in a one-time payment. A greater number will receive $300 instead, but most will receive nothing. The Liberal government has suggested seniors do not need special payments for the most part because their income has not been disrupted in the same way as many other Canadians. So can you give us a better idea of the types of increased costs that seniors are facing as a result of this pandemic?
Sure. So a lot of our own members have seen an increase in the cost of living, whether that's in dispensing fees for prescription medications or in the delivery of groceries, for example. A lot of seniors over the age of 70 been told to stay home, and so I've had to incur those costs, particularly low-income seniors who may not have access to family supports or other community supports. They're disproportionately impacted by this. On top of that, we also know that a number of community support programs have shut down. 40% of food banks in Toronto, for example, shut down because of COVID-19, because of physical distancing restrictions, and also because of a shortage of volunteers. And so these are things that seniors depend on: discounted laundry services. And so these are some of the ways in which, to not mention, some of the programs, tax support programs for seniors to file their taxes, those have also had to close their doors as a result, and seniors are being forced to incur those costs in addition.
Yeah, very good points. Can you give us any idea of an average price of these new costs at all? This would give us a better idea of how adequate or inadequate the government assistance is.
It's difficult to say because on top of that, we also...
Ms. Lennox, your sound is very difficult for the translators. Could you speak into your mic if you got one?
Yes. Second.
I'll pause Mr. Weber's time here for a minute.
Thank you.
I took it out because it kept cutting out. Can you hear me now?
Yes.
I can hear you. How are we for interpretation?
So it's difficult to say because on top of those out-of-pocket expenses, seniors have also seen significant declines in their retirement savings. And what we know about CARP members is that a majority of them are very concerned about outliving their savings. But when we talk about hard out-of-pocket costs, one of the biggest out-of-pocket expenses is on prescription co-payments. As you know, many of the provinces have gone to have restricted people to a 30.
I'm sorry, you are cutting out a little bit, but I guess speak very slowly, carefully, and we'll do the best we can.
I'm sorry, it could be my internet connection. So many provinces and territories have moved to a 30-day supply on prescription medications. Previous to this, it was 90 days. And the reason for it is because of supply chain issues and fears of a hoarding mentality at the beginning. When we've surveyed our members, on average, CARP members take around 4 prescription medications each, with some taking more than 10. So now that they've been reduced to a 30-day supply, they're having to pay prescription co-payments on each of those medications, and they do add up. Depending on where you live in the country, those, as you know, those co-payments and dispensing fees, they do vary. So I don't know if I could give you a hard cost on because it really depends. It's very individualized. It would depend on the individual.
Yeah. Do you feel that this is an adequate number that the government is providing the seniors?
No, I do not.
Yeah. Thank you for that. I'll change my questioning over to Ms. McKenzie now. Many people have changed their buying habits as a result of this pandemic, of course, and we see that there's more online buying and curbside pickups. Now, many of these seniors do not have that technical comfort to shop online, and many others no longer drive, and curbside pickup is a challenge. So, of course, family and friends are helping, but that will not always be possible. So what is your organization doing, Ms. McKenzie, to help these seniors adjust to this new economy, and how can the government help?
Well, I think that certainly we've encouraged the government around the creation of what I've talked about already, the BC 211 program. And then I think in the longer term of the many, we've talked a lot about long-term care, but the other fault line that's been exposed in all of this is that the vulnerability of seniors who are not connected to the internet, perhaps, so being able to organize those types of deliveries, and who don't have a network of family to help them. Because right now, there's an outpouring of volunteers. Some of those volunteers are materializing because they have time. And as people return to work, some of that, I suspect, will dissipate as people return to their paid employment and have less time for volunteer work. But I think it is certainly something that we need to think about, which is when, because there could be another wave, we need to remember that certainly here in British Columbia, where we're certainly on the downside of the curve, that we are expecting potentially another outbreak in the fall. And so what does that look like? And how are we going to make sure that people get the supplies that they do? And I think we certainly need, I think the federal leadership around when the federal government provided some funding to the United Way, sort of at a federal level, the province here in British Columbia had already done that. I think that that's helpful as well, because it's going to give an opportunity for organizations on the ground to organize in their community around how are we going to get these seniors the things that they need, remembering that this is time limited to some extent.
Yeah. Thank you, Mr. Weber. Dr. Jaksic, over to you. 5 minutes, please.
Thank you very much, Chair. And thank you to all our witnesses today. You obviously have valuable insights to help our seniors, and particularly those living in long-term care, and obviously feel very passionate. I'd like to turn to the question of the physical structure, particularly of long-term care homes, retirement homes. And Ms. Hall, you referenced this in your remarks, and I understand you've done a number of interviews on that particular subject. Here in York Region, our municipal homes, actually one was redeveloped about 20 years ago, and there was sufficient space to have nearly all single rooms, a couple of double rooms, particularly for couples who obviously might want to be together in the same facility. And in fact, those our two facilities here in York Region, neither have had a COVID-19 outbreak. So I would just ask you to talk a little bit more about the importance, what the government might do to assist in the redevelopment.
Thank you. So just to restate, the physical infrastructure, when we're talking about something that is as infectious as COVID-19, is critically important. That ability to put in place...
Sorry, Ms. Hall, could you speak more into your mic?
Sorry, I do that every time. My apologies. The ability to put the recommendations in place from the Public Health Agency of Canada, I think are critical going forward. So I think that there are many tangible examples of where homes that have a more modern design have had greater success in being able to prevent the spread of COVID. And, we've noted the narrow hallways and the inability to practice social distancing amongst the residents. But there's also issues like shared washroom space. And so making sure that in addition to that private room, that there's also washroom space that can be utilized by an individual. So there's a number of, I think, factors that need to be considered from a standards point of view. And as we think about, what role the federal government can play, assisting in some of those structural pieces could be very beneficial.
And Minister McKenna has, as you, I think, alluded to, made some provision potentially for shovel-ready projects in particular, but there does not seem to be any constraints on what she's proposing that might not be able to assist long-term care. Is that the way you've seen it?
Yes, I mean, we certainly took note when she said that. And previously, I think there was, when the housing dollars were made available federally, there was some sense that perhaps nursing homes or long-term care homes could tap into that line of funding, but that was not the case. So we were encouraged when we heard that shovel-ready project line, because we absolutely have projects that could move forward quickly, especially with the support of the federal government.
And Monsieur Brunet, I believe in your pre-budget submission, February 2020, you also talked about investing in seniors' housing, where care is provided by using federal infrastructure funding to create some 42,000 new beds and help rebuild old homes. So I presume you concur that this would be an area that should be pursued.
Certainly, I think it makes sense, but it is a challenge, because I've seen in my experience old premises being held by people very, very voluntarily, being well-intended, smelling places, corridors where it smells good. We're talking about in time of peace, not in time of crisis. But sometimes the walls, the structure, doesn't change the situation of how it is being led and operated. With all due respect, yes, it certainly helps. I've seen some places downtown, some villages being destructed because it was too old and being built elsewhere in the countryside. And people were so sad because they wouldn't see anyone walking on the streets. So, sometimes you have good points, you want to modernize, but elders in Saint-Agathe, Quebec, are sad because the place they have built is in the woods. They don't see anyone walking around, and elders want to see kids and people walking in the center of the city. So there is a challenge, but I understand that, yes, it should be modernized. Last summer or the summer before, Mr. Barrett said old places could not be air conditioned. We know that it is being air conditioned when the intention is there, because all administrators, even in old places, have air conditioning in their offices.
Thank you, Dr. Jaksic.
Thank you.
Ms. Wong, over to you now. Ms. Wong, please go ahead with 5 minutes. Sorry, Ms. Wong, you're muted still.
Okay, now I'm unmuted. Okay, thank you very much, Mr. Chair. And first of all, I'd like to who did very excellent presentations, and I've met some of you before in my former role. And again, thank you very much for doing such a good job. And most of you have already covered a pretty wide range of topics. And of course, in some of the things we, as the federal
I'm sorry,
committee,
Ms. Wong. Could you move your mic? Yeah, that's a little bit higher up, closer to your mouth.
Better?
I think so. Let's try that.
Is it better now?
A little down.
Okay.
A little down.
Yeah.
Right there. No, not so far. No, up. Good. Well, a little bit more up.
Yeah, how will you stop me?
Okay, there we go.
You'll stop my time. Okay,
Down,
thank you very much.
Right next to your mouth, not up by your eyes. Down.
All right. I don't know. This is probably not the right size for me.
That'll be good. That'll be good. Right there.
Okay.
Go ahead. Thank you.
No. Still not okay? Oh gosh.
No, I think it's good there. Let's try that. Right there.
All right. Can you all hear me now? Okay. I was thanking everybody for doing such a great job and in your research and in your service. And as I said, I've worked with some of you before in my former capacity. Now, I like to look at more as the federal leadership, how, we as a nation should work not only during, this COVID-19 challenges, but also for other jurisdictions as well. I understand that every year there should be a FPT.
Sorry, Ms. Wong.
I don't know why is this echoing.
Yeah. Make sure your headset is on properly, and that the mic is right next to your mouth.
Let me see if I could.
Okay, I'm gonna pause your
Is
time
it okay?
for
No.
well, let's get this sorted out so we can. People
Is
can
it
hear
better
you.
now? Is it better now?
No, it's very, very bad sound.
Oh gosh. How about now? No?
I think that's better. Just say a few words. We'll see.
Testing, 1, 2, 3, 4.
There's a whole bunch of echo there.
Yeah, I don't know why it's echoing.
Do you have your speakers on, or are you using your headset?
Using my headset. How about now? Is it better? No.
No, not good. Not good.
Not good. Okay. I did. How about now?
Hi, it's a technician here in the room. I think it was all right for a moment when you had it in front of your face there. It was just you were still touching it a lot, and it was very loud in here. So if you could just leave it there and not touch it and talk for a moment, we'll try and hear what it sounds like.
Yeah.
If you could just
How
talk
about
for a
now?
moment. Can you talk about
There's
the weather?
still the echo.
You're getting an echo?
Yeah. From my side, maybe I'm hearing myself talking.
Yeah, if you could just talk for a second, it's just adjusting itself.
We'll suspend the meeting for just a few minutes and get this sorted out. So meeting suspended.
I'm sorry for this, and maybe I should change. No, I don't have another headset with me.
No, Ms. Wong, what's happening is every time you're touching the mic and moving it, it's trying to adjust itself again. So it's kind of resetting it when you touch it. So can you just talk maybe about the weather or something for a moment? We'll see. Just don't touch the mic, and you can.
All right. How about now?
So can you just talk for a moment? Just about the weather.
It's
or
still
anything
echoing.
It might go away. It just needs to. You just need to talk for a moment, please, if you don't mind.
Okay. Now, okay, I'll resume.
Well, so the meeting is still under suspension.
The FPT.
Sorry, this is the technician. The meeting is suspended right now. I just want to get some audio from you. If you can just talk for a moment.
Yeah, this is the only time when I have problem with this.
It's like
I've been doing Zooming all the time, and it seems to be okay, except for this one.
Yeah, I think it seems to be A little bit better now. I think it's just that there was, with all the kerfuffle of you touching it and adjusting your headset and stuff like that, I think it caused some issues. Are you still receiving that echo?
Testing?
Are you getting that
No.
echo still? Because the sound seems fine on this side.
No, I can still hear my echo. I don't know. It's a delay.
You're hearing yourself back?
I'm hearing myself. Is there something from on the control right now here? Because, as I said, I've never had that problem before.
Yeah, we were having some issues hearing you as well.
Could we check to make sure she's going through her headset and not the speakers?
Yeah, I'll try and coach through. Ms. Wong, are you on a computer, like a laptop or something of the like?
No, I'm using the Pro, the House of Commons.
Okay.
Sent me.
On the Zoom app, so on the bottom left, there's a mute button. You might have clicked it earlier to unmute yourself.
Okay, now this is the mute.
Yeah, so next to that little mute button, there's a little up arrow. Can you click that? Okay, so you're muted right now, so unfortunately I can't hear you, but next to that mute button, there's a little up arrow. If you click that, there should be an option to select your headset. Can you see that? I'm still not seeing you here, or sorry, hearing you.
So Ms. Wong, you're muted, but there's a button next to that, a little up arrow that we want you to click on to see the settings for where your sound is coming out. So you're still muted, we can't hear you.
Yeah, no, still. Oh.
Okay, so we're hearing you now. You're unmuted. Oh, we lost you again.
It's okay?
So are you still hearing yourself? Are you still hearing yourself? We're hearing you still. We're hearing you now.
Okay. No, there's no echo now.
Okay, so can you talk again just for one moment, just so we can make sure we're not going to get any funny business on our end, and then I think we might be good to go.
Okay. Can you all hear me now? Oh, I still hear my own echo. Oh, that is a circle next. Let me see. Talk to Cortana. So what does it mean? No, it's not.
No, definitely don't touch that one.
No, okay. Maybe later. Okay. Now,
it might be pertinent at this point. Maybe I can have someone call you. We can. Yeah, there's something significantly wrong here. I think we'll have to have someone maybe reach out to you offline.
Got it. Okay. Now, let me see if I can use my picture instead. Maybe that will help.
Is it possible that it's her headphones? I know that this morning we were on a Zoom meeting and she had no trouble. I just don't recall if she had her headphones on.
I did. Now it seems to be okay, right?
The audio does seem to be much better. It might be connection with that. Are you still hearing yourself?
Well, so I will not show my face then.
Are you hearing yourself though? Is that still an issue?
I can still hear myself.
Okay, yeah, that I'm not sure of, and I'm having trouble picturing that. So I don't know. It's up to you if you're able to continue that way.
Well, I don't mind hearing myself, but if you can all hear me.
There's a huge echo. Translation will never be able to handle that.
Oh, dear.
It's okay for translators. It's okay for interpreters.
But if you're not hearing her well in Zoom, Mr. McKinnon, that might also be a problem. But that might be within Zoom. In the committee room, we're not hearing an echo.
Sorry, I didn't quite hear you.
Sorry, that was directed at Mr. McKinnon. But of course, I'm just listening to the committee room. We're not hearing an echo here, so that might be something else entirely.
So right there, briefly, Alice, you were fine. Just talk a bit. Tell us about the weather in Richmond.
Okay, it started raining last night, but now it's okay. Oh, no echo now.
That's beautiful.
Okay, now I can move on. Sorry, can I start right from the beginning?
No, we have to. We're still suspended. So, as translation, are you okay with the sound at this point?
Is it better now?
Okay.
Yes, it is. Thank you
All
very
that
much.
being said and done, we shall now resume the meeting. The meeting is resumed. Please go ahead. I'm not sure. I think you have 3 minutes left.
Okay, sorry for that. And so, first of all, I'd like to thank all the witnesses, and you have covered a very wide range. And I think one of the things we have been talking about is about federal leadership. My understanding is there should have been many what we call FPTs, the federal, provincial, territorial ministers responsible for seniors looking after these. I don't know whether our current minister has done that, and definitely this is the right time for especially for the long-term care homes and other jurisdictions which are mainly provincial, and yet we need to take the leadership. Now, when we talk about seniors in social isolation, we're looking at 3 different groups of people: those who are in seniors' homes, those who are living in their family members, and those who are really living by themselves. So when we look at their physical and mental needs, I think we should have different reactions. And so I'd like to ask if any of our witnesses who could really shed some light about the different needs of these 3 different groups. Maybe I can ask Ms. Mackenzie then. Seniors in social isolation, the 3 different groups.
Yes, thank you, Alice. And you've identified that there are, as I say, COVID-19 looks different depending on whether you're living alone, whether you're living with somebody, and whether you're living in long-term care. And I think we need to look at that. And long-term care is a big focus of COVID, and we've spent a lot of time talking about it, and there are definitely changes that need to be made. But we also we cannot forget the home care piece and what that needs to look like and how robust that needs to be. And then we need to look at the piece that is about the seniors who live alone, and how are we going to keep them connected to the non-health services that they need, because if we don't, then they're going to develop healthcare needs. And I think we can step back, maybe not today, but in a few weeks or months, and take a look at, okay, what really has happened here across a broad spectrum of seniors and their needs, and what is it that requires federal leadership in order to affect the kind of changes that are needed. I think that would be a very good way for the federal government to approach it.
Yes, and just now we did our witnesses did mention a lot about the hardware, like what sort of structures there need to be in redoing some of the seniors' homes and the challenges, and then at the same time we're looking at the software part, like that's not the only issue now and in the future for our caring for the seniors, especially in those seniors' homes. Now, so we are looking at training as well. Now, of course, I think one of the witnesses did mention that we can have some short-term solutions, but I think people didn't seem to realize. Some people don't realize that it is actual skilled work. It's not just anybody who can do it, and I, especially the passion part. I was able to visit some homes lately because I was helping a youth group to deliver masks to all these different seniors' homes in the Lower Mainland, and then of course there's a shortage of PPEs, and the community is stepping up to help them, and some of them were so passionate. I was almost in tears when
I'm sorry. Could we wrap it up, please?
So my question is, we should really care for the caregivers as well. Those who are informal, who are helping from homes, their relatives and friends, and also those who are working in these seniors' homes. The frontline people, I think this is important that we look after them as well, caring for the carers. So that is the message I wanted everybody to have in mind, and also share my experiences with them. So thank you very much for allowing me, and I apologize for the inadequacy of my equipment. As Tamara's witnessed, I haven't had any problem except for this committee. I don't know, there's something against me, it seems so. Thank you very much.
Okay, thank you. We go now to Mr. Fisher. Mr. Fisher, you have 5 minutes. Please go ahead.
Thank you very much, Mr. Chair, and as always, thanks very much to all the witnesses that are here today. I want to go to Ms. Hall. Yesterday, the Prime Minister and the Minister of Seniors announced the tax-free $300 on the OAS and an additional $200 to those who qualify for GIS, positively impacting 6 to 8 million Canadians, plus previous announcements with regards to funding community orgs. So I'm interested in your thoughts on that announcement yesterday as it pertains to seniors.
Well, it has been mentioned. As it has been noted, hopefully that's clear. There definitely are those individuals across the country who will largely benefit from this. I think there are questions around the scope of the benefit and is it sufficient? Does it reach enough seniors who actually have needs? Then there's questions around, for those who are in care, will some of that be extended to them? And how does that translate? So, of course, I think it's a positive move to be able to support people who have needs that are unique to the COVID outbreak. But does it also apply? There's other questions about who exactly does it apply to. More information would be helpful.
Thank you for that. Ms. McKenzie, you, I think, had every member of our committee writing down the freakout factor and highlighting it when you said that. I kind of feel that the focus and discussion around long-term care workers and clients became all about PPE and not necessarily about control measures or basic hygiene measures. And I thought maybe you could just tell us a little bit about those early days.
Well, certainly when we look at Lynn Valley and what happened there, it for want of a better term, I call it clinical leadership and strong clinical leadership. And I think that is needed, particularly right now in the environment of community care aides, who are 70% of the care staffing in our nursing homes in this country, are personal support workers, as you call them in the East, and care aides, as we call them out West. And so understanding infection control, understanding how PPE works, understanding the use of N95 masks and aerosolizing procedures. And that, I think, was a piece that was missing. And I think it weaves through this issue around the care aides in our care homes, and this is a place where the federal government could show leadership. I'm struck by the fact that we have national, not just standards, but exams for RNs and LPNs, but we don't have any such national standard for care aides. And part of the way that you make a person feel valued and part of the way that you attract people to something called a profession is that you actually provide those standards. In the 20 years that I worked with predominantly care aides, I worked with nurses and LPNs as well, they craved the training. They wanted to be able to take the courses. And our system is set up, it's very frustrating. I could send my nurses on courses. I didn't have to backfill them. It was easy. Oh, I send my care aide on a course. I've got to backfill them. Oh, that costs money. And so they sort of get left behind in all of it. And I think that is an area, federal leadership around standards, not just around what happens in care homes and care ratios, but around the level of training. I am a big proponent of standardized exams. There have to be practical and written. I do understand that. And it doesn't tell the whole story. It does not get to the piece around the EQ, the emotional quotient that is needed to be able to provide this kind of care. And Jody is quite right. The wrong person with the right training is as much a recipe for disaster. In fact, I would say more so than the right person with the wrong training. And so we have to be careful about that. But certainly PPE is one example where if we had better training, more high-level training, more standardized training, we could have a lot of concern and anxiety has been created around this, that I think when we step back and look at it, we're going to realize that, yes, that was important, but really there was this other piece over here. So I think that is a key area where the federal government could show leadership as well.
Thank you, Mr. Fisher.
Thank you.
We go now to Monsieur Desilets. Monsieur Désolé, 2 minutes et demi, s'il vous plaît.
Oui, merci, Monsieur le Président.
Yes, thank you. Thank you to all the witnesses. And thank you for having answered our call and for having shared your expertise. We very much appreciate that. My question is for Mr. Brunet. You referred to April 25th. Sorry. Mr. Brunet, you referred to your report. Not your report, but your bill that was tabled on April 25th, and that talks about desired supervision, about direction, about control. Could you speak to this a little bit more, and also how this bill was received? These proposals were made to Minister McCann and Mrs. Blais in January 2019. And we told them, please don't create another commission. We don't want a parliamentary commission. All of this is written down. Everything has been documented. For the past 30 years, we know how to take care of an elderly person, how to lift a person who's paralyzed, who has different healthcare conditions. We know how to get someone ready to eat if they have issues. Everything is written down, but this has to be translated into reality. So we looked at all these reports that generally come from the Department of Health in Quebec, and we are suggesting a minimum bill for minimum care and services, whether they be clinical services or laundry, food services, choice of menu. All of this is included. It just has to be applied. Thank you. In collective action, you speak about ill treatment. Could you give us your definition of an ill treatment? Well, or mistreatment or ill treatment was integrated in a bill from the Liberal government, and it's the same definition as the one that's given by the United Nations. It's a gesture or the omission of a gesture that should be full of confidence. And this could make a difference and can have a negative effect between a serene, comfortable experience and something that is not. So we use this concept of mistreatment. It doesn't seem to exist anywhere else in Canada. We wanted to use this to speak to mistreatment, whether it be basic minimum levels for hygiene, for food. We have many issues that were raised well before COVID-19, and that a class action suit has been accepted by the Superior Court, and we're going ahead. Okay, so according to you in Quebec, what's the situation for basic care in these long-term care homes? Do we have basic services? Are we talking about 1 bath, 2 baths, 1 bath every 2 weeks? What is it? Well, ever since 2003, there is documentation that exists under the former Minister of Health, Mr. Couillard, and these regulations have not been applied. Everything is documented. We fought so that people would have their laundry services paid for. We're fighting so that people who are not incontinent are not forced to wear a diaper if they're not incontinent. This is horrible. We're fighting for this, and it's unbelievable, isn't it? But we have very serious issues such as these, and this is why there's a class action suit. This is basic care. How to wash clothes. The lawyer said, well, how do you wash clothes? Well, same as you wash your clothes at your house. Whites with the whites, colors with the colors, not everything all together.
We go now to Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you. Ms. Hall, I just want to be clear on this. I understand your evidence. Is it your view that the long-term care sector is not entitled to apply for federal infrastructure funding?
Yes. That's our understanding that under the existing
Microphone.
infrastructure, funds through the housing strategy, that we were not eligible for application.
Now, we've heard evidence, and my research has shown that there's a critical problem with infrastructure in long-term care homes in this country. Has the federal government, given you any explanation or principled reason why long-term care facilities would not qualify for that funding?
There seemed to be a lack of understanding and perhaps confusion. Some have felt that we were eligible for that. And in fact, we've determined that we are not. So that was a critical area for us to understand. I think that it's often cited as well that there's, provincial jurisdiction. And so that becomes the realm of the provinces. And I think it's just important to note that with the aging transition of our population, and that increasing healthcare needs or health system cost on the provincial governments, that they have extremely limited resources. So we seem to have fallen into this bit of a gray space, if I can call it that. And certainly, we have respect between the federal and provincial responsibilities, but we do see this as an area of shared responsibility, and that's what we're asking for the federal government to come alongside of the provinces and with this sector to help us address those infrastructure needs.
Well, certainly. I mean, this federal government gave several $1 billions to the provinces targeted at mental health, which also is administered by the provinces. And I remember in 2009, after the recession, the Conservative government at the time made funds available for infrastructure for recreational facilities like curling rinks and arenas. So certainly the federal government can there's no constitutional barrier to that. Ms. Langall, to you, I know that you had the opportunity to tour senior homes and long-term care facilities in British Columbia when you were president of Costco. I also would like you to start talking about your views on home care and how this might fit into the equation. What did you notice when you toured those homes, and how does home care fit into the equation in your view?
Well, one of the reasons why we're looking at phasing out of long-term care, although you can't eliminate it altogether, is that people generally prefer to be in their own homes. And I don't think I have to show any studies. I think that's pretty evident from all kinds of literature that's around.
I'm sorry, Ms. Langhoff, could you speak louder, please?
Sure, I will try to do that. There, obviously, not everyone should be in long-term care facilities. And I know that some of them are better than others, and people are more or less comfortable in them, depending. But I think the overwhelming majority of people just would prefer not to be there. And in order for them not to be there, unless they have really difficult or complicated health issues that require 24/7 care, many of their needs could be met at home. If the home was adapted in a way that's going to be useful in terms of whatever the needs are. So one of the things that we see is that there had been a contraction of the services for home care. So not everything was covered, and there seemed to be an artificial distinction between housekeeping, meal preparation, and administration of medication or other therapeutics, as though they are separate. So if your home is not a hygienic one, that's not going to be a good situation. So I don't know how you can divorce cleaning or cleanliness and laundry services and so on from health conditions in general. And now that that may seem odd, but I think that the services to seniors has to combine or span a whole spectrum of services that perhaps are punctuated by the end station, which is generally speaking a palliative care or a long-term care situation, and that's an inevitable process of aging. Well, all of us will face that sooner or later, and hopefully all of us it'll be later. But that's the way that goes. But I think that in terms of what we're looking at now, is that this particular pandemic has given us the opportunity to have a critical look at, and some critical thinking towards the kinds of things that would help to make things better. And I think that people like Dr. Armstrong and Isabel McKenzie and a lot of others have developed, have amassed a great deal of information. So doing more detailed studies, we really prefer not to happen. It's like gathering all that stuff together may be a good idea, and then see how it can be applied in a national way. Seniors are running out of time. I'm in my 70s. I don't want to wait another 15 years before we tackle this sucker. It's got to get fixed. We got to do it. It'd be a dumb thing if we did not use this opportunity, as Isabel was mentioning, as you have huge numbers of people waking up to the realities that
Ms. Langhoff, could we wrap
help.
it up, please?
Thank you very much. I really appreciate being on the soapbox.
Thank you, and we enjoy it as well.
Thank you.
So that brings round 3 to a close, and I would like to thank all the witnesses for sharing with us your time this afternoon and all of your valuable information. It's most helpful to our work, and thank you to the members of the committee as well. And with that meeting is, and also for everyone for bearing with us through our technical difficulties. And thank you for all the technicians who day by day get out there and solve our problems for us. So thank you all, and meeting adjourned.